I will read to you what's on the prepared statement here, and that would be that I'm introducing Dr. Clifton Kenon, Jr., and so I'll make a statement to say that he just kind of laughed about the being referred to as a doctor, that he kind of protested a bit to say that he prefers to be always known as a nurse first. So Dr. Clifton Kenon, Jr. is the director of the Office of Women's Health and the Maternal Child Health Consultant for the Aberdeen Area Office of the Indian Health Service. In his role at the Aberdeen Area Office, he has area-wide oversight of maternal child health programs and the Aberdeen Area Mobile Mammogram Unit. His duties include assisting the service units with program implementation, quality assurance, policy development and implementation, as well as research and evidence-based practice initiatives. Clifton is a native of North Carolina, where he attended Winston-Salem State University for his Bachelor of Science in Nursing, the University of North Carolina at Charlotte for a double master's degree in nursing, and Chatham University for a doctorate degree in nursing. He is currently a second doctoral student at the University of Tennessee. Clifton is internationally certified as a lactation consultant. Clifton's experiences include being a labor and delivery nurse, lactation consultant, hospital operations administrator, and nurse educator. Since coming on board with the Indian Health Service, Clifton has been honored by the Surgeon General of the United States, the Chief Nurse of the United States Public Health Service, the Secretary of the Department of Health and Human Services, and the Director of the Indian Health Service. He took home the top national award in 2013 for the Indian Health Service, the Reyes Award, making him the first nurse ever to receive this award. He has represented the agency at various national meetings, including a presentation at the White House, 2 national publications, and presentations for presidential cabinet members. Clifton comes to the Indian Health Service from Duke University Medical Center, where he worked as a labor and delivery nurse and lactation consultant. He was the founding co-chairperson for the National IHS Obstetrical Nurse Residency. I'm happy to introduce or turn it over to Dr. Clifton Kenon, Jr.
Thank you. Thank you very much. Good morning. How's everybody feel? You know, I am not here to lecture you and go through 1,000 slides and make you have to follow along and pretend like you're taking notes, that you're really interested in everything that I'm saying. Because I know as well as you know that's not true. I go to a lot of conferences, and hey, it is what it is. We're just going to have a conversation today. Is everybody okay with that? All right. You know, I've been to Oklahoma twice in my life, but you know, I feel right at home. You're looking at a true Southern boy, born and bred on the coast of North Carolina in a little town where we sat on our front porches and we drank sweet tea and ate sandwiches and just kind of thought we were just living it up. And when I come to Oklahoma, I relive those experiences because I believe people like sweet tea. And I think they like sandwiches. And I think they like sitting on their porch, watching the cars go by, wondering what people are actually doing, when it's probably none of our business anyway. You know, last year I had the outstanding honor to be here in Oklahoma, and I met some of you lovely people last year. I was here at the State A1 conference, and I got to talk about baby friendly, and I got to talk to my colleagues down here in Oklahoma about the changes that we're going to have to make in healthcare. I went to a restaurant in Oklahoma, and I have never gotten so much food on one plate in my entire life. And I'm from North Carolina. So my wife and I began to ask, you know, is this for one person? And the lady responds, well, absolutely. You know, you just take it home and you just eat as you go along. And, you know, down here, when you come to a restaurant, you get your money's worth. And I will bear witness to that. If you want to feed your whole family, there's restaurants you can go to in Oklahoma City and just get one plate. All right, I would like to give honor to my beautiful companion. We're coming up on our 1-year anniversary. We actually honeymooned for a little bit in Oklahoma last year because when I agreed to speak in Oklahoma, I did not know that I was going to be married when the speech actually came. So from Jamaica, we came to Oklahoma to hang out with everyone. So Oklahoma will forever have a soft spot in my heart. So I would just want to give honor to my beautiful wife who has so graciously jumped on board and supported my work with breastfeeding and the International Code of Marketing of Breast Milk Substitutes. Hey, behind every good man, there's a good woman. Am I right? You know I am. When we look back at why we are here today, the year 1969 resonates within my heart. And that was the year that a gentleman by the name of Derek Reliff started a conversation that likely made him one of the most unpopular people that ever existed. He was the director of the Caribbean Food and Nutrition Institute, and he wrote a U.S. government brochure warning of the dangers of improperly used breast milk substitutes. Because he looked in the mirror and because he decided that what was going on was not right, all of us sit here today to continue to build upon the legacy that so many people before us have paved the way for. That was 1966, 1969. It was not until 1971 where his concerns actually fell on people's ears that were actually willing to actually make this a larger issue. Even then, people mocked him and said, "You're being ridiculous. You're making a mountain out of a molehill. It's not really that serious." But ladies and gentlemen, I'm here to tell you today it is that serious. And each and every one of us has to take our mirrors out. And we have to start with ourselves and look in those mirrors. Because the world is depending on someone to make the changes, just as Mr. Reliff did. I want to extend you greetings from the Northern Plains area of the Indian Health Service, North Dakota, South Dakota, Iowa, and Nebraska, where every one of our hospitals are baby-friendly, including the first and only baby-friendly hospitals in the 2 poorest counties in the United States. When I look out over this lovely audience today, see, there's something about being in the South. The people are so lovely. They come to conferences and stuff. They're so dressed up. They got the heels on. They look so well, and they come so professionally. You know, up on the Northern Plains, we come for warmth more than anything else. You know, we might wear a suit, but we might have 3 layers on the top of it because the place that we're meeting at doesn't necessarily want to run their heating bills all the way up. So when I look over this audience, I ask the question, and I ask you to ask the same question: why are we here? Some of us are here because we truly believe in the Baby Friendly Hospital Initiative. I want to say all of us are here, and I'm overwhelmed with joy with that thought that when I look out and look in the eyes of each and every one of you, you are here because you know that someone has to do this outstanding work. Now, let's be real. Where are my labor and delivery nurses at in here? Put your hands up. Be proud about it. We are the greatest people that ever existed. For all of you that are not labor and delivery nurses, I'm so sorry, but it is what it is. I am so proud to have spent my entire nursing career doing nothing but obstetrics. I would venture to say that there are many others of you in here that have only ever done obstetrics in your nursing career. Is that correct? I know that people are beating down the doors to leave obstetrics and go to psych and to go to critical care and to go to geriatrics. But I'm not one of those people. You see, when I was 17 years old, I graduated nursing school and I became a labor and delivery nurse. I remember being in a medical surgical clinical, and I remember having to attempt to suction someone. And I remember, you know, the patient not responding and the nurse feeling like he couldn't respond. And I knew right then at the age of 16 that I could never do anything except labor and delivery. So at the young age of 17, I showed up at Duke on their doorstep and I said, you know what, I need a job. And I can only work labor and delivery. I went to nursing school knowing that this is a hard specialty to get in, but this is the only thing I can do. 10 years later, just about, the lady at Duke said, I'm going to take a chance with you because anyone that shows up and just demands a job for these reasons deserves a chance. So there's some of us that likely go to conferences because, we kind of need a break from work. Anybody ever go to a meeting because they just need to breathe a little bit from their unit? I know you guys are out there because I do that too. Sometimes it's great being a labor and delivery nurse, but sometimes you sign up to go to a meeting because it truly is a break. Hey, I've been a nurse manager and I know that there's a lot of these meetings that people go to they aren't a bit more interested in, but it still is a break off their floor. So what I want to tell each and every one of you today is thank you. Thank you for being here, and thank you for being willing to be the persons that are going to lead a new era of healthcare and wellness for the generations to come. See, the reason that we're all here is actually pretty simple. We all have a responsibility for our future generations. And contrary to popular opinion, the future generations and their livelihood lies within the decisions that we make today. Not the decisions that were made 30 years ago and not the decisions that are going to be made 30 years from now. The decisions that are made today will have an everlasting impact. Think about it. How many of you work in a place where there are newborn nurseries that you can't get rid of? Do you think that that was something that was created just 10 years ago? Think about how long implications last when something is done. Who would have ever thought that today, in 2014, we would be sitting here trying to figure out how to get rid of a dilapidated old model that basically concluded that mothers were not competent to be in the same room as their mothers, so we had to take closets and put beautiful paint on the wall and keep the babies in there because that was a safety mechanism. We are still fighting that battle today. The choices that we make today will likely have implications that will last for the next 50 or 60 years. Everybody agree with that? We should just be able to close these nurseries down, right? All the evidence behind nurseries is non-existent. The reason behind their originality has been defamed. We know that people are competent to take care of their children, even though they were competent then because we kept babies in the nursery for all night, but then we sent them home, and then all of a sudden, you got to take care of your own child now. But it was unsafe for you to do that in the hospital where there are trained healthcare people around you to help you at the drop of a button. Hey, I'm right. You know I am. We're telling the truth. But unfortunately, in healthcare, change is very, very difficult. So the reason that each and every one of you is here is because there's a charge that sits on your life and there's a charge that sits on your career. And it's a calling that speaks to your enthusiasm. Finally, we're all here because families all over Oklahoma are depending on people just like you, just like me, to pave the way for improved health and a decrease in health alterations. And if you're here because you needed a break or your unit sent you and there was no one else to go, that's fine. We're glad to have you too. If I were to ask you today, is the current system of delivering maternity care supportive of mothers and families? How many would say yes? Is the current healthcare system supportive of people, period? How many would say yes? I think there is a lot to be said in it that we have a lot of work to do. However, the work is not going to do itself, and people actually have to do it. How many of us here would say breastfeeding is the unanimously best way to feed infants and small children? Duh, right? This is not rocket science. You don't even have to read the journal. No offense, Ann. You don't have to look through CINAHL. You don't have to do a literature review to know that. This is common sense, okay? So I'm not here today to prove that breastfeeding is the best. I think we all know that. But what I am here to prove to you today and to encourage you in is that the Baby Friendly Hospital Initiative is the only program that healthcare organizations have ever done where when it was implemented correctly, it was 100% successful. How many people have heard of baby-friendly hospitals that started, that went back to doing things the way they did before? They do not exist. So if I can tell you about a program that has worked in practically every part of the world that it has been implemented in, that alone stands reason that it should be worth trying. Am I correct? Think about all the other stuff that we've tried in healthcare that was not really well thought out, that we had to do, and we knew that it wasn't going to work. But today we have a program that has worked. It worked at Claremore. It worked in North Dakota. It worked in Boston. It works in California. Works in Africa. Works in Canada. And it will work here in Oklahoma too. So, I want to show you guys Cooley. Cooley was our first baby-friendly baby in North Dakota. Cooley is 2 years old now, and guess what? I'm sorry, I can't hear you. He's still, of course, absolutely. Cooley says, this is one of our restaurants on our reservation. If breast milk isn't on the menu, I'm not eating here. Cooley has been our poster baby for Baby Friendly, and his mom is perhaps our largest advocate in North Dakota for the Baby Friendly Hospital Initiative. So my question to you is Baby Friendly really necessary? Is there another way that we can do this? You know, we get asked this question a lot. I'm sure Ann and myself, we go around to a lot of places and people say, is there another way that this can be done? Do we have to do it this way? My question, when I'm asked that question, I respond with the question is, what is the other way? There is no other way that has evidence to support other than the 10 steps to successful breastfeeding, coupled with the International Code of Marketing of Breast Milk Substitutes, conglomerated into what we know as the Baby Friendly Hospital Initiative. It's like so necessary that even Michelle Obama has called the Baby Friendly spirit. And today, that song, Teach Me How to Dougie, Michelle Obama can probably Dougie better than anyone you have ever met. And when she's talking about childhood obesity and breastfeeding and doing the Dougie, I love that video that Becky played because truly, breastfeeding saves lives. How many people know breastfeeding saves lives? If you don't know, ask someone, because I can bear witness. In the poorest counties in the United States, breastfeeding saves lives where people are so realistically poor that they are not financially able to acquire artificial substances to feed their children. And even if they were, they may not have a car to get to the 2 hours to the nearest store where they need to buy such substances. I am a living witness today that breastfeeding saves lives. Breastfeeding changes communities. On the Rosebud Reservation in Todd County, South Dakota, our entire reservation is 100% compliant with the International Code of Marketing, including every store on the reservation. There are no formula displays that exist anywhere on our reservation, and our entire tribe backs us up in that because we know that after the Baby Friendly Hospital Initiative, our community was changed. And if you don't believe me, you may make the 13-hour trip up to Rosebud, and you may just ride on our reservation and ask anyone that's walking through about breastfeeding, and I can guarantee you they will be able to tell you about it. Breastfeeding strengthens families. I think now more than ever here in this country, we need strong families. Everyone agree? Breastfeeding strengthens families. I have seen this time and time again where breastfeeding has brought families together because they can unite around a common bond of health and wellness. Finally, breastfeeding saves money. I don't know about you, and I don't know about your population, but the population that we serve and the population in most parts of the country, there is not an endless supply of money that people actually have where they are actually realistically able to afford artificial substances such as breast milk substitutes. Maybe Oklahoma is a very wealthy state where there's all this money. Even in North Dakota, which is the most wealthy state in the union, our families cannot afford that. So let's talk about these 10 steps. Are there really 10 steps? I think there's 9. No one should be stumped with step 1. No one. If there is anyone in here that is stumped with step 1 about the breastfeeding policy, I'm going to fix your problem in about 2 seconds. There are numerous breastfeeding policies that have been written for you that you will never have to pick up a pen and ever write. So let's just talk about 9 steps, because there's not really 10 steps, because 1 step is universal here in that you can go on the internet and you can download it and you have step 1 done. Anybody held up by a policy? Great. I'm glad to hear that. I get really anxious when I talk to facilities and they say, we need help with our policy. No, just download one off the internet. You can have mine. You can have the one we use nationwide. You can have one from Massachusetts. Just download it and put your name on it. No one is going to sue you for copyright infringement. I promise you. Step 2, train all healthcare staff in the skills necessary to implement this policy. How many of you guys are having difficulty with training healthcare staff? How many people have difficulty in training people, period? Right? You know, today it's HIPAA, tomorrow it's meaningful use, it's the Affordable Care Act, utilization review, there's a new policy, a new piece of equipment, a new law. Somebody got bored and made up a new thing to make my life more complicated, so forth. Today, when I think about training, I will tell you whatever you do to make your training program possible, you make it as flexible as ever. There should be no excuses why anyone on your staff cannot get their training done. Now, I worked night shift for a long time, and I'm telling you, when you've worked all night and you've labored and you've been to C-sections and you've done deliveries and people have been cranky and you're sweaty and you don't smell good and people have the nerve to ask you to stay over and take a class during the day. Anybody ever been in that predicament before? They are insane. I'm just not going to do it. If your training program is going to be effective, it has got to meet the needs of the people you are trying to train. Meaning if people work at night, training has to be done at night. If people work weekend option, training will have to be done on the weekend. As long as we continue to yoke people up in the bondage of that training is only going to be offered when it's convenient for the trainer, never minding what everyone else has going on in their own personal life, our training is never going to be successful. First piece of advice, ladies and gentlemen, training has to be flexible. We as healthcare professionals don't do very well with rigidity. How many of you guys do well with rigidity? We don't. And I don't want you guys to keep looking at Cooley because he's such a cute and awesome baby that, I don't want you guys to get mesmerized with him. So we're going to change the slide. Babies were born to breastfeed. I'm just saying, this is our Turtle Mountain campaign. We had this made on sweatsuits. We didn't have t-shirts. It's really too cold to wear t-shirts, so we had sweatsuits. We have babies were born to breastfeed on the sweatshirt, and then down the right pants leg it says, I'm just saying. I'm just saying. Step 3, inform all pregnant women about the benefits and the management of breastfeeding. That's it. That is all you do. Okay? I remember when we started talking about changing our prenatal education up in the Dakotas, and people were saying it's going to be a whole lot of work. Now we have to do something extra. No, we're going to stop everything that you did before, and all we're going to do now is train people about breastfeeding. That's all we talk about. How many people have been harassed with the most ridiculous question that I believe exists in obstetrics? Are you going to breastfeed or bottle feed? What is that going to change about anything in your prenatal care? Nothing. You're not ready to breastfeed. You're not ready to bottle feed. So me asking you that question is not going to make a difference when you go into labor or anything. It is the most ridiculous question, and we ask that question nowhere in the Dakotas at this point. Okay? When I talk about informing all pregnant women about the benefits and the management of breastfeeding, that's all we talk about. We don't talk about artificial feeding in our hospitals at all, under any circumstances. Everything that we talk about is breastfeeding because there's only one natural way to feed children. Okay? So, what I did with my staff, because anytime you have change, you go around with papers, you tell people they got to do something extra. People don't really like it. Okay? No more questions. Everyone is just considered to breastfeed. You know, in OB, how many times do we ask people on their first pregnancy, are you going to have a vaginal delivery or a C-section? Do we ask people that? Why? Because it's assumed that everyone is going to have their baby in the most natural, feasible way to do it, which is a vaginal delivery. Why don't we assume the same thing for how people are going to feed their children? Why don't we assume the same thing for how people are going to feed their children? At our hospitals in the Dakotas and all across Indian Health Service, everyone is assumed to be breastfeeding. Everyone is assumed to be having a vaginal delivery, and the two norms go together. When we talk about our prenatal education, our patients are tired, our nurses are overworked, probably everyone is underpaid. Anybody in here feel like they're paid exactly what they're worth? Where are you? Get them. So when we talk about prenatal education, it's condensed in 5-minute sessions and that's it. People don't have a lot of time to wait. People oftentimes have to find a ride to come to the clinic. Oftentimes people's spouses have to take time off work and they don't have all day to sit in a breastfeeding education session, of which oftentimes very few pieces of information that you've actually presented actually follows the patient out of the door. There are no multiple handouts, and if you have multiple handouts, I would encourage you to get rid of them right now. Everything at our hospitals is in one book, and that one book covers your entire prenatal care. So you might ask, what if the patient loses the book? Who says we give the patient the book to go home? We might archive the book, and every time they come to the hospital, we give it to them. It's sort of like a library book, and they check it out, and we go over it with them, and then we don't have to keep buying books. People are much, much more interested in having something to read while they're waiting for their appointment. We do 5-minute sessions, and the computer prompts you. We do breastfeeding education at the start of a positive pregnancy test. If you come in and your positive pregnancy test is verified, you start learning about skin to skin. Whether you're 7 weeks or whether you're 17 weeks, you begin your breastfeeding education course. Now, if you come to the hospital for about 15 of your prenatal visits, you've heard our information for 15 times, but only in 5-minute increments. There's two things that we always talk about with moms. One of them is your baby will always stay with you. We do not market our practices as baby-friendly. We market our practices as safety issues. We have got to move away from we are doing all of this for baby-friendly. We are doing all of this because this is the safest, most evidence-based way to provide healthcare. It is not baby-friendly. Baby-friendly is an award. It is not a model of care, and we need to understand that. Do not market your practices as these. We are doing this because of baby-friendly. We're doing this because it's the safest, most effective way to provide health care. So babies always stay with their moms. We have no nurseries. Frankly, I don't know about you, but in our hospitals, we don't have a lot of space, and our nurseries are much, much more functional as storage rooms than they ever were as closets that people brought their children into. The other thing that we tell our moms when our moms ask, well, what if I fall asleep? Who will watch my baby? You know, let's be honest. How many of you guys in here work in the newborn nursery? Who works in the newborn nursery? I worked in the newborn nursery for a little while, and one night there was like 20 babies. You know, do people realistically expect that one nurse can watch all 20 babies at one time? Usually the babies are watching themselves, and when they cry or when you do rounds, you sort of go and check on them. But if anyone in here believes that because they're sitting in a little room that we have termed nursery, and they're watching the babies, that you can actually have your eyes on 15 or 20 infants at one time, you are absolutely out of your mind. Okay? So that's how we tell our mothers about it. We have had no complaints in 2 years since we did Baby Friendly of moms and babies being separated. All of our babies stay in the rooms with the mom. As far as helping mothers initiate breastfeeding within the first hour of birth, we taught all of our patients, and we just asked them the question, when you have your child, do you want the first person that comes into contact with your child to be a stranger, or do you want it to be you? How many people have thought about it that way? The first voice that your baby hears, who do you want it to be? I don't have children yet. God is going to bless us with children, I do believe. But I can tell you that I want the first voice that they hear and the first people they interact with to be their parents and not a total stranger. And every one of our patients wanted the same thing. And I can guarantee that your patients want that too. Now, how many people have had patients say, I don't want the baby on me until the baby is cleaned off? That's fine. Absolutely fine. You put a towel or a blanket on the mom's abdomen and you put the baby up there and you clean it off and then you take it off. That's all you have to do. So how many people have got these roadblocks with nurses where they just can't do skin to skin? I just can't do it. Anybody experience that? hey, you guys are in good shape because, hey, we even experienced that where nurses, I just can't do this. I've got to take the baby to the warm because I can't do my assessment. This became a nursing competition. Okay? And I hate to say this, but it truly is true, but we sort of did reverse psychology in it, that we played games with our highly experienced nurses to the extent that, so you mean to tell me that you've been a nurse for 20 years and the nurse that's only been a nurse for a year can do an assessment on the abdomen and you can't? Hey, that's true. If you've been a nurse for 20 years and you can't get your vital signs with the baby or do your ab guards with the baby on the thing, and I have my 1-year nurse 1 year out of school that can do that, we have a problem, a big one. When we started producing it like that, Skin to Skin became 100% compliant. Hey, I'm not going to let these new graduate nurses come out and outdo me. Same thing happened with rooming in. We do 100% of all of our procedures in the room except circumcision. Every one of our blood draws, blood cultures, IVs, everything is started at the bedside. How many people do not believe that's possible? You know, it was hard. It was really, really, really hard. We had some nurses that I just can't do that. I don't feel safe. Why is it in a hospital? OB is the only place where we take people from room to room to room to do stuff. When every other patient in the hospital gets all their stuff done in the room, and the only patients in the hospital that are not sick and are healthy are paraded around in these caravans all day to get these menial little things done. How much sense does that make? If you were in the ICU and you needed to have your blood drawn, would somebody load you up and move you all the way out, draw your blood, and then bring you back? And I'll be honest with you, I absolutely hated checking armbands. If the moms and the dads had the babies all dressed up in pretty clothes and you had to unwrap them and check the armbands as you were bringing the baby in and out, it is just so much greater to just have the baby in there all the time. They can dress the baby all up in pretty clothes and you never have to worry about that.